But let me get back again, Cora, let me ask you, back to the point around quality of life and patient-reported outcomes. I mean, the regulatory agencies have worked with investigators and institutions to, to really highly recommend, strong recommend to get that information, right? How our patients are feeling while they go on these treatments. And by the way, since we prolong time and they live longer, right, it's very important to make sure they're not being harmed by throwing more therapies at the patients, right? So it's always a hard topic. I feel like we don't talk as much about patient-reported outcomes and quality of life in general. We look at the curves at times. It's sometimes hard to interpret, at least to me. How do you take that? Like when you have a patient in front of you, right? You're going to tell them that he's going to have more treatment. So how do you balance that?
Well, first of all, I agree with everything that was said, but we must also take into account the comorbidities and the age of our patients. So if our patients, even if they have visceral disease, if they're like 89, 90 years old or have serious heart problems or something, these are not the patients we're going to start with triplet therapy. They're not. I mean, we really need to take into account the patient that we're talking about, the quality and their quality of life before and after. And just, adding chemotherapy and triplet therapy is more serious than just doing doublet therapy. So I think that that's really seriously important. And then the other thing is that when patients are on the triplet therapy, for instance, in the Arison's trial, they're on it for longer because they do better. So they have more time to develop more side effects because they're on it for longer. But which often happens in many trials when patients are on longer time or they're on twice as much, they have twice as much time to develop the side effects. I don't think that we have one quality of life instrument that's really dedicated to all of this. There are geriatric scales or EORTC quality of life scales that look a lot at urinary symptoms and other kinds of things, but I don't think that we have one that we have universally decided that this FACT-P or this EORTC is the one that we should be using for elderly patients, for patients on getting this kind of treatment. So and I think we need that.
Absolutely. And so if I were to summarize, if I'm hearing correctly for our audience, even though we're giving more therapies to patients, quality of life is shown in all the trials, right, to be at least preserved, if not better. In other words,
they say that.
Right? In other words, more is not worse in this case, right? So I think that's one message. And the second one, which I think is implied, implicitly what you're describing is, we all assume treatment intensification should be done for the vast majority of the patients, assuming that life expectancy is driven by prostate cancer. So if we see a patient where life expectancy is shortened because they have comorbidities, because advanced age, patient is very frail. So every time we answer the question, do we think this patient will unfortunately die from prostate cancer, we should definitely consider the treatment intensification. And maybe in my practice, curious to hear you guys, the folks where I don't think about treatment intensification, where life expectancy is really short, a year, 2 years, 3 years, in my practice, including the times that I spend at the hospital in service, it's about 10-15%. So I would argue probably 8 of 10 patients that I know with metastatic prostate cancer should be offered treatment intensification, not only be all the benefit in regards to the addition of ARPI with or without chemo, but also because we're actually not harming them. Patients telling us they feel the same, if not better. Is that fair? Do you agree with this?
A treatment intensification with a doublet, yes. Treatment, once we start talking about a triplet, I think that that's something different. I participated in the Arison's trial. I believe in the data, but whenever we have a clinical trial, we always select the patients that are on it, and that's not the same exactly as real-world data. When you see afterwards the real-world data, it's often very different. So I think patients are highly selected that go on trials. So I agree with you that most of the patients can be on doublet therapy, irrespective of their age, depending, like that is what I try to do and not just give ADT. But for triplet therapy, I think age is very important, and I tend to give it more to younger patients who are fit with chemotherapy.
So since you mentioned that, it's interesting because the real world data suggests that we're probably not using more than 10% chemo in more than 10% of the times. Do you have a different experience in academia? What's your,
Certainly in this ivory tower here, we're we're probably more like 50-60%. But I think that communication around quality of life involves patient trade-offs. There's going to be a drop in quality of life if you pick triplet therapy for about 3 to 6 months, and then a rebound. And then the goal is to delay that deterioration in quality of life due to the disease and the comorbidity of disease progression, which really leads to the massive quality of life drop when you get to metastatic CRPC. And so the goal is to delay that into the future. And so you're having that conversation with patients right up front. A little bit of a drop in the quality of life early to prevent a bigger drop and delay that later.
Regarding the triple therapy.
In regard to triple. With doublet therapy, I think, you do have more side effects with doublet therapy. Even, some of the best ARPIs that we have, there's always a little bit more. Certainly there's more costs. So there's financial toxicity for some patients, but you see a bit more fatigue and hot flashes and effects on skeletal health, stamina. That's why we were talking about intermittent therapy initially. This is now lifelong continuous therapy, and so we can't neglect that it has some effects. But the goal is to minimize that by maximizing survivorship, like we talked about, monitoring, encouraging fitness goals and a healthy diet and things like that. But and bone health as well. We do see increased fractures and frailty in our patients. So having those conversations up front would probably help improve those numbers.
We should be looking at bone density on all of our patients. We should talk about their diet. We should talk about exercise. These are so important.
Right. As they live longer, right? The topic you brought it up a few times, you guys too, right? The topic around cardio-oncology. Yes. In addition to all the other factors, absolutely. By the way, since we're talking about that, and it's going to be, we're going to talk about it again, but since we're in this topic, how do you address patients with bone metastasis and bone modifying agents? It's always I find it sometimes is a topic of confusion. One to prevent osteoporosis, osteopenia, and the other one to prevent skeletal-related events. Evan, can you just really quick go through how do you handle bone modifying agents for patients with metastatic hormone-sensitive disease?
Yeah, absolutely. I discuss with the patient the risk of developing osteoporosis. I have them all take calcium, vitamin D. I talk to them about exercise and some resistance exercise training. Those are the simple things that I do. And then I do a baseline DEXA scan, and I do DEXA scans for surveillance while on androgen. How often do you do it? I used to do it more frequently, but I now probably do it about once every other year. So if you do it more frequently than that, you don't really see that enough changes to act on it, but about once every other year. And I do use agents like zoledronic acid, and I do use denosumab as well. I use the 60 milligrams every 6-month dose there for osteoporosis. Now, just to be clear, zoledronic acid has been looked at as a potential anti-neoplastic or survival drug in the STAMPEDE study. It was looked at in an older CALGB study that accrued about 90% of the patients and never finished, but there was no survival signal there. So for that reason, I don't use the doses and the frequency that we use zoledronic acid and we use denosumab for skeletal-related events, which would be for metastatic castration-resistant prostate cancer. I use it just for the osteoporosis issues and osteopenia even. Yes.
Perfect. Whereas for MCRPC, just to remind the audience, you're not doing it twice a year or once a year with denosumab or zoledronic acid. You do it once a month, every 3 months?
The studies would show that you should do it, about once a month. That being said and done, with bisphosphonates, we know they hang out for a long time, and there have been other studies that have pooled together prostate and breast and other solid tumor patients that show quarterly is just fine. So, I think, it also depends. If you look at that population, the goal is to prevent skeletal-related events there. And most of our agents that are fairly efficacious also have, their anti-tumor effect, they have some anti-skeletal-related events effect. Now, we may want to talk a little bit later about, a study that we recently showed some benefits here just at ESMO with radium-223, the PEACE-3 study, where it was critically important to add, the bone protective agents. And, how does that work?